Welcome to MAP, the bi-weekly market access podcast hosted by me, Dr. Stefan Walzer. I am the innovator of Market Access 4.0 and a health economist by training and working in the fields of market access, reimbursement, pricing, and health economics since 2004. Discover Market Access 4.0 and unveil the future with our innovative solutions. Max Insights, our fast and easy AI-based reimbursement planning platform. Dobo, our new revolutionizing way of creating reimbursement dossiers across the globe with the first and only dossier writing AI bot. Cubo, our new AI-based objection handling platform. And Waffle, train with Waffle's virtual reality genius in an immersive environment and with an AI-based counterpart. We are Market Access 4.0. So check out our website, marketaccess4-0.com. And now let's dive into the current discussions, processes, and trends in market access across the globe. Welcome to another show of the Market Access podcast. Today I have the pleasure as well to welcome a good friend and a very good expert in terms of patient involvement and communication, who is Erika Bersin. And Erika, please feel free to quickly introduce yourself.
Thank you, Stefan. My name is Erika Bersin, and I've worked in and around the pharmaceutical industry as a strategic communicator for about 30 years now, and going on 9 years, which is hard to believe. I started my own business in the US, in New York, doing that. So I'm the president and founder of ERO Health Communications based in New York City. And I'm excited to be on your podcast.
Perfect. Yes, thank you, Erika. So I think one of the, let's say, key drivers, how I at least know you, beyond, let's say, communication, where we as well had the first kind of contacts during our joint industry times, is also, let's say, patient involvement, and that's probably also in a more broader sense. I mean, when we would generally be thinking about market access or health technology assessments and everything around that, I would generally say maybe patients are not really involved. Interestingly, of course, you just said you're located in New York. You have also experienced personally and also professionally, let's say, healthcare and some of the systems across Europe. So what is maybe the kind of biggest difference if we would be maybe rather thinking about patient involvement, and maybe start rather a bit top level, firstly, if you would maybe even think about between Europe in a broader sense and the US?
So I think that over the last decade or so, patient involvement in HTA and payer decision-making has moved from, ad hoc token input to more systematic and methodical where possible. But as we know, this highly depends on the regulatory landscape of the country and the region. In some countries, patients are routinely engaged as experts on committees, patient preference studies, and real-world evidence, and training other patients to serve as experts. In doing some research for our discussion, Europe, although not a monolith by any means, has really taken the lead in this realm. And I think that the US is somewhere in the middle because we have a very fragmented payer system. And then I think, as is usual, the Asia Pacific region is cautious, but making headway in this space as well. And I think partly Europe has taken the front seat or the lead in this, is that many countries in Europe, or most countries on the continent, have the same kind of single payer system set up. So I think it's easier from that perspective to potentially integrate patients into the discussions, identify the right patients to participate in these efforts. I think that in a different way, the US has access to a host of patient organizations and advocacy groups across all disease areas. And we do that well here and have worked really hard to integrate them into discussions and having a seat at the table as opposed to being an afterthought.
This is, I think, a very interesting one. I mean, as you just said, I mean, it might be a bit easier in, let's say, systems we see here across Europe, whether it's maybe the typical NHS systems like we see in the UK, for example, or other systems maybe a bit more competitive like in Germany or in Switzerland, versus maybe a system, as you have just described it briefly, in the US. What I would be really interested in, and I have had more experience, of course, across Europe. I mean, how would you really, let's say in detail rather, how would you really involve a patient in such a kind of recommended US system? I mean, you have so many different payers privately, you have, of course, the important public system, but I mean, how would you do that? And would you just generally, let's say there might be a kind of patient committee, which should generally be as well advised, or should maybe advise, right, the other way around, advise maybe different payer groups? I mean, how could I envision that, which is a bit different, of course, as in Europe?
Right. To your point, having lived in Switzerland for 4 years, their system is set up very much similar to the US, the system where it is, by and large, most people have private health insurance, and you have a choice between dozens of insurance companies that you can use. So that system was more familiar to me because it mirrored similar to the insurance companies here in the US, but where it differed is that if your doctor prescribed it, they covered it. So, which is very different here in the US. And I know to a degree it's very similar to that in other European countries as well. As I like to say, what's one of the most bizarre things about our insurance here in the US is that, let's say, if I'm across New York City and I, heaven forbid, get hit by a bus crossing the street, they take me to a local hospital and they can't see my records. They can't see my health records. So as simple as this is going to sound, because it's not simple, it's extremely complicated and complex, connecting systems alone would go a long way in helping to bring the patient voice to the table. Because in New York, even, we have the most hospitals and doctors' offices per capita in New York City than anywhere in the world. And I actually live in the epicenter of that. You have hospitals that rent space from each other in buildings, let alone being around the corner from each other. So one would think that having that connection would make this much easier. But everybody wants to hoard their information, which creates barriers to the activity that we're discussing here. But what I would say in the US is that I think one of the biggest organizations that's actually doing this work amazingly is called PCORI. It's the Patient-Centered Outcomes Research Institute. And in my experience, they are setting the tone, and they have become the leader in the US for integrating patients into all aspects of the discussions. The other thing we run into here in the US is that we have high-level data in the US that companies rely on, and it's called IMS. The challenge with that data is, and I'm not telling you anything you don't already know, and certainly probably what most of our listeners know, is that a lot of the data that's incorporated or collected in that system is based on physicians getting procedures covered by insurance. and office visits covered by insurance instead of what might actually be the issue. So it's a bit of a shell game. So again, you're working with data that is reported to get insurance companies to pay for the treatment and the office visits. So it's kind of one of those things where do you turn to get accurate data reflected? Because I think that everything relies on being able to trust the data that you're basing decisions on, whether it's going to market with treatments, whether it's being an individual patient who's looking at their records. I've had to correct things in my own records, not because my, doctor or nurse practitioner was being careless, but it was so that I could get the treatment I needed.
Gotcha. Yeah, that's an interesting one. While you were just speaking, I was also just thinking, the systems generally are so fundamentally different. And I think one of the key things, what I learned as well, already, let's say, very early in my career, was especially when you would be thinking about, let's say, stakeholders like hospitals, like insurance companies in the US, they're basically commercially driven. Which is different to, let's say, I would say, to the vast majority of other systems, which has a lot of, let's say, maybe call it negative incentives towards the care and outcomes of patients. But would that not be maybe as well a potential opportunity as well to get maybe the patient even closer, because you might get a bit of a closer look to your kind of client, if I would see that as a crucial one?
Yeah, I see where you're going with that. Interestingly enough, most hospitals in the US are on paper considered nonprofits.
Mm-hmm. On paper.
However, when senior leaders are making 7-figure incomes, there's a conflict. There's an inherent conflict. You would think, but a lot of the bigger academic institutions in the US have patient advisory committees. Mm-hmm. So to a degree, those voices are incorporated. But as we know, even the best groups can do better. By and large, even in 2025, in my direct experience, patients are still an afterthought in the process, from the start of protocol design to the end and follow-up.
Yeah.
And as I like to say, the supply chain isn't complete until the medicine or treatment gets to the patient. So seemingly, to me, the patient is the most important person in the conversation, but doesn't often have a seat at the table.
Yeah. No, I'm totally with you. And the interesting thing is also when you would be thinking about, let's say, payer decisions, which is a lot of times basically between the payer and the pharmaceutical company, if you take it like that, right? That's already the first one, right? But the second one is then still, there are discussions on the patient relevance of the outcomes of the clinical study. So the question is basically, of course, we can discuss about different kind of things and aspects, and maybe if we take death, I think nobody would discuss about it, right? But what about, for example, different pain levels, or even in oncology, progression-free survival, right? You could probably debate for hours and probably days whether this is patient relevant or not. And I would bet that if you speak with patients, most of them would see progression-free survival as highly relevant, right?
Oh, absolutely. I've had to, as a communicator, I've had to explain many times over my 3 decades, regardless of where I was, either in a pharmaceutical company or a clinical research organization, or even in an academic health center, when you're talking about progression-free survival versus overall survival in a study, overall survival means people aren't dying. They're actually living. So to your point, progression-free survival for somebody living with an advanced cancer, it means they're living.
Exactly. No, and I'm totally with you. I think it has also positive impact on your psychology, on your quality of life, and sometimes even on the pain, right? Depending a bit on the let's say specific cancer you have. But ultimately, I think one of the key things, and you touched base as well, just very briefly on that, when you just as well brought the pharma companies in there, right? And we're discussing about hospitals, patient, let's say, involvement, insurers, patient involvement. But what about pharma companies? What is your experience on that? Are they taking the impact by patients a bit closer, maybe even a bit more professional, I would say, early stages in the clinical trial kind of input, but also maybe later on when it really gets into not only market access, but rather patient access?
Yeah, I think that most of the top, I would say probably the top 10 or so pharmaceutical companies, at least in the US, and, a lot of companies, the US is the largest market they have. So it stands to reason that, either the affiliate or if they're headquartered here, that it would happen here. And also because of the different regulatory systems and requirements around the world. I do think that there are pharmaceutical companies that are doing good with this, but I also think that there is more room because, as with any company, they tend to only engage and elevate the voices that reinforce the direction that they want to go in. And I think it's imperative to have different lived experiences at the table and to also have point counterpoint. Because, it's not all sunshine and roses when you're living with a significant illness. And what I didn't include in my introduction is that I've lived with multiple sclerosis for 17 years. So as with anyone who works in our industry, we have a unique perspective that not only is this the field that we work in, but it's also we use the treatments and we experience the benefits and the cons directly.
Yeah, exactly.
And the cons take a toll on your health. And I think it's important for these messages to also be included in how they can do better.
I can only agree with that. And I mean, I think an important consideration is of course as well how do patients, let's say, get finally then as well their medicine, right? I mean, it sounds so kind of odd. I mean, ultimately, if you get let's say an appointment with a physician and maybe you get the prescription, there's still the step until the prescription is maybe then with the patient. I mean, and I think even this step could sometimes be an additional hurdle where people would need to let's say people responsible person, the pharmaceutical industry, but also maybe the insurers should be thinking about, right?
I mean, absolutely. And I think that the challenging part for me to digest is that they know these issues and they choose to ignore them. They know the issues. They've gotten the feedback for years and years. And but where I would say, and for me, the positive is that I did live in another country. So I had insight into A, using another system, but B, also learning about the systems from the countries around them and the rest of Europe. But as an example, in Switzerland, when I was diagnosed there and I decided at the time which treatment I wanted to go on, my insurance company there, because my doctor prescribed it, there was a brief waiting period for to process the paperwork, but that was, I think, a week maybe. And then it was clear sailing from there because my doctor prescribed it. And having moved over there relatively healthy, I didn't know what the challenges were going to be when I moved home to the US. And I have literally had to beg for my medicine here, for my MS. Not once, not twice, not a dozen times, because of all of the steps in the way between my doctor and me. So the challenge is when you talk about the payer stakeholder discussion, everyone will say these things are complex, but they don't have to be. Because healthcare should not be big business. I've said this since I found my way into this industry. I don't begrudge a company making a profit, but it's how much on the backs of people who need healthcare. Because everybody is going to need something at some point in their life, whether they're young, old, or in between.
Yeah.
Including the people making these rules and regulations.
Yes, absolutely. And sometimes it's even that kind of new perspective and fresh perspective. If you have somebody sitting in front of you who have either had the experience or knowing somebody who had the experience on that given disease, the discussion is different, which is a normal, a typical kind of human mankind, right? I mean, how we basically move forward with that. I mean, I like to still have, let's say, or I'm a positive thinking person, so I like to still have maybe a good example where the involvement of the patient voice, maybe patient advocacy groups, etc., has really made a difference. Do you have anything off the shelves, maybe anything where you can just say, look, this is how I would see, even if it's just one example, this is how I would see life with the patient impact and input as well should be as it is?
I do. And this is how advocacy actually started in the mid 80s when people with HIV and AIDS were just literally dying in the streets. So the HIV AIDS community really created advocacy. They literally created it. And others came after them, like the breast cancer community, and learned from what they did. And it was really born in places like San Francisco and Washington, D.C. The Whitman Walker Clinic in Washington, D.C., I think was the first clinic for people living with HIV and AIDS. It came out of San Francisco, DC, and New York City because they were being ignored and people were literally dying at home in the streets. And they said, we're not going to stand for this anymore. And that community took to the streets, and patient advocacy was born out of that. And then the breast cancer community came along, learned from what the HIV community did, and took it from there. Obviously, it shouldn't be this way, but people pay attention to groups that they can relate to, because obviously in the 80s, 90s, into the 2000s, the stigma around people with HIV and AIDS was tremendous. So they were looked at as pariahs and people that potentially weren't even worth saving. Whereas the breast cancer community, the pink ribbon and the pinkification of everything, and everybody knows somebody whose mom or sister or daughter or cousin got breast cancer or died from breast cancer. So it's huge globally now, breast cancer activism. So I would say that those two groups do it really well and get a seat at the table. Now, on the other end of the spectrum for this, in terms of access and payers, is the ALS community. And outside of the US, that's motor neuron disease. That diagnosis is a death sentence. It's not a matter of if, it's a matter of when. So the notion that, there's only 2 or 3 treatments, and mostly that's to treat side effects of the disease. It's not meant to slow down the disease really or stop it. The notion that they're not allowed to take on the risk when they're a community that is going to die is I think grossly inappropriate. But again, these are made largely based on financial decisions as opposed to what can we learn from the treatment, because I like to say I'm the only N of 1 that matters. If something works for me, that's really what I care about. And so given how small the ALS community is, if something works for 100 of them, and that furthers research for down the road, because I know more and more people being diagnosed with ALS because we have the internet and they're out there talking about it. So, I know countries weigh the cost benefit ratios of this, but I also think that there's huge research opportunities to learn from the people that do benefit from a disease that no two people experience alike. And that's true with most diseases. It's just that some of them are more alike than similar. So medicines for different diseases, sort of like MS, do treat and keep it at bay more so than a disease that's as insidious as ALS. I think you have two ends of the spectrum, but that community, I would say that community is just as loud at this point as the HIV, AIDS, and breast cancer. And I wanted to kind of look at different spectrums because there are definitely, other disease areas that also do a good job, but those are two that definitely come top of mind.
Yeah, no, I think those are really great examples. I fully agree. I
think it's true in other regions where those diseases are also prevalent, other countries, other regions.
No, I agree, and I think I think I've seen that as well with the HIV/AIDS and also with breast cancer in different countries across different kind of either activities, screening, influencing politics, but also around market access or pricing decisions. I think there were a lot of good examples, and I agree with you. It's made prominent ones because you can maybe also read it in different newspapers, news feeds, and so on. But there are as well others who are as well doing a very good job. I think the important thing is these are examples. And I think the idea is rather, because we're moving already towards a bit the end of the recording, is looking a bit towards the future. And if I would ask you basically, how you would envision the future, especially when looking maybe around the impact of patients on maybe say generally healthcare decision making. How would you see that hopefully happening? So positive kind of idea in the next 5 years, for example.
So I think that future success looks like access decisions being co-authored by patients that turn lived experience into measurable decision-ready evidence. But like anything in life, the importance of human thoughts and emotion should never be discounted, because I know that, I've seen this cycle of buzzwords and phrases and actions. And, AI is, my 79-year-old dad is talking about AI and I'm trying to explain to him, what it is. So I think that it's important that we keep the human voice included, and we make sure that people participating get the credit just like anybody else, whether that's being an author on papers being produced or being included on the study protocols. If you're not incorporating people who are the end user of what you're doing, be it a medicine, a diagnostic tool, the conversation isn't complete without us at the table. And I say that as someone who works in the field, but is also someone living with a chronic illness. I tell people all the time, the conversation is not complete. And also, no decisions for us without us.
Yeah. No, I can only agree. And I think I like the idea. Let's complete the picture as well in the future to have, let's say, a complete decision making with all relevant and with all stakeholders, not only relevant, I would say, at the table. Erica, that was good fun as always. Great insights. I learned again a lot. So thanks a lot for your time, Erica.
Thank you. This was great.
Market access this time thought much broader than we normally discuss about it, rather as having patient access. What does that really mean? I mean, ultimately, that's also what we have heard quite greatly, Erica, how drugs or medtech devices are getting to the patient, which is ultimately the definition of market access. It sounds so obvious. However, we've just heard about different hurdles in different systems as well, which might not take the patient in the focus into the center. And this has sometimes as well to do with, for example, different systems. US, a lot has, of course, been taken as commercially interested. Commercial is the big driver. However, we were also discussing about it, that this might potentially be maybe even a positive point, as this might as well potentially help differentiating from the different hospitals, or let's say between each other. Anyhow, I think the key core thing is also that not only, let's say, providers, healthcare providers like physicians or hospitals would need to take the patient rather really into the center of it in terms of access, but also when it comes to the pharma companies. Ultimately, great sharing of best practices when Erica was also moving between the great patient advocacy advances and examples from HIV, AIDS, breast cancer, but also the latest one with ALS community. Ultimately, what is really important also towards the end was the quote what Erica said, if looking to the future, access decisions should be co-authored in the future. Let's take that as a goal, as a mandate to act. That was an episode of MAP, the Market Access podcast provided by Mars Market Access and Pricing Strategy, which is your healthcare consultancy in the German-speaking markets. MAP is available every second week with a new episode, so watch out. And in case you might have questions, contact me directly and or visit our website on www.marketaccess-pricingstrategy.de.